Uh, right. Now I'm going to start this lecture. Right. This is regarding, y'all are okay to start, ne, Dalamai? Dasuni?
Yes, madam.
Okay, right. So, fluid and electrolyte therapy. Now, I know when y'all were in the fourth year or whatever, I'm sure we may have done fluid balance lecture, right? That is in that, I'm 100% sure we may have done different types of fluids and what it should be, when, at what situations mostly those are needed and things like that. Now, this is just a retreat of that as well as to catch up some other aspects of fluid management, which you might need it in different situations, right? So I'm going to catch all the, or touch all the situations of where the fluids are being given. Okay, right. Okay, so the aims of fluid therapy is to certainly for the correction of shock or to resuscitate. When you have a low fluid volumes in the body, like hypovolemia and all, to correct the shock status and establish the proper tissue perfusion. That is the main reason. I mean, this is the only reason we were discussing when we were giving the fluid balance first lecture. Okay, so why? Because the cardiac output needs to be maintained. Hope you remember this. And we have to improve the fluids because the cardiac output determinants are the stroke volume and the heart rate. So the stroke volume, it depends on the how nicely it is contracted and the volume status. And then the volume status is the one that we are handling with the fluids. Hopefully you remember that. Okay, right. So that is one reason, or the main reason is the correction of shock status. And so the correction of shock status and also the correction of fluid deficit, right? Rather than going into shock, there can be deficits and ongoing losses, right? So that is also one of our aims of fluid therapy, and to provide the maintenance requirement. So you and me always want a maintenance. So that is also one reason that we need to think about the fluid therapy and the proper selection of fluid so as to correct the electrolyte and acid base disorders. So that is also one reason we think of the fluid therapy. So either to correct the shock status or to maintain to give the deficit and the ongoing loss, and to give the maintenance fluid, and also to correct the electrolyte and acid base disorders. So these are the reasons of fluid therapy. Okay, right. So when you think about the goals of fluid therapy, that is to provide the right amount of fluid, right amount of right fluid in the right time, at the right time. That's the mainstay of this. Now you have to give the right amount of fluid, right amount at the right time. So the basic principle is fluid replacement should be as close as possible in volume and composition to those fluids lost for that given patient. So if it is a vomiting, that has to be a different fluid. Then it is a bleeding, that has to be a different fluid, and things like that. Okay. So these are the basic principles of thinking of fluid therapy. Okay. So the first one, or the first step, is the assessment. So we need to know how much to give. So while planning the fluid therapy, it is essential to consider the volume status of the patient, isn't it? Say that can be done by the assessment of the dehydration, the severity of dehydration, and how much the fluid the patient needs will come as the status of the dehydration of the patient, right? Okay, so that is the volume. Then the etiology of dehydration needs to be thought of, because the dehydration could be due to vomiting, it could be due to bleeding, it could be due to diarrhea, it could be due to any. So the etiology also you need to know. Otherwise, you cannot think of the which fluid. Then I remember I told you right amount of right fluid, right? So the amount is okay, volume is okay. Which one is the right fluid is the etiology decides, right? And the presence of electrolyte disorders, if it is so, by the sodium and the potassium, you need to think, and the presence of the acid-base disorders also you need to think. And also, the patient may be having associated coexisting disorders like diabetes, hypertension, things like that. Say if it is a patient is already a diabetic patient, that person's fluid balance could be not the same as non-diabetic patient coming into the same situation, right? A patient who is a hypertensive, we know the level of the blood pressure may be different to what normotensive patient needs to, like that. So you need to have the coexisting disorder, some idea. Say congestive heart failure, you don't just push fluids because he goes into failure, like renal failure, liver failure. So all these things also needs to be thought of when you think of the fluids, right? Okay, so that's the assessment. Then the next step is you should calculate the volume of intravenous fluids that you needed. And on the basis of volume status, the amount of IV fluids to be infused is calculated. Obviously, amount of the dehydration or the loss we have to take it, right? Then, so we realize how much the assessment and then the calculation of volume. And then the step 3 is selection of the intravenous fluids, right? So we have discussed what are the types of fluids that we are having, crystalloids and colloids and all. So according to the nature of the fluid deficit and the presence of the electrolyte and acid-base disorder, you have to select the appropriate IV fluid. And yeah, our choices are crystalloids or colloids, and what crystalloid and what colloid. Okay. So then, so hope you remember in this, you remember like we have crystalloids, we have normal saline. Tell me some crystalloids, Samay. We have normal saline. What else?
5% dextrose.
No. See, what is the definition of crystalloids? The definition of crystalloid is electrolyte solution. Harida. Okay. So then that solution must have electrolytes. So tell me one.
Ringer's lactate.
Yes, good. So the normal saline is one, no? You have what are the electrolytes the normal saline is having?
Sodium and chloride.
Good, correct. So the sodium and the chloride. Yes, the Ringer's lactate is also one such solution, right? So it has kavisha monad ekේ තියෙන sodium තියෙනවා chloride තියෙනවා තව මොනවද?
Potassium,
Little bit of
calcium,
little bit of
and
potassium, චූට්ටක් calcium and එහෙම තියෙනවා. Then
lactate.
yeah. Okay, so you have lactate. Right, okay. So because we cannot have the bicarbonate, you have it as lactate, and lactate when it goes to the body makes into the bicarbonate at the liver, right? Okay. So like that. So then another fluid, crystalloid. So the 5% dextrose doesn't have electrolytes, isn't it? It has sugar and the water, right? But people used to classify that also as the electrolyte, crystalloid, because we have no other place to put that poor fluid, which we are using so much. So actually it's not a crystalloid, by definition. Okay, but else?
Mannitol, madam.
No, child, mannitol is a drug. It's not a fluid. It's a drug, isn't it?
Yes, ma'am.
Yeah. You can try another one. Me, ඔයගොල්ලන්ගේ lecture එකට ඇවිල්ලා නැහැ කියලා හොඳටම පේනවා attendance. Anybody? How about n by 2 saline? N bhagya? N by 2 saline? Have you seen n by 2? Have you seen n by 2 saline? Tamai? You all have lost the contact of mine. Tamai, have you all lost the contact of mine?
No, madam, we can hear you.
Yeah. Okay. So there's something called n by 2 saline. Okay. That is the concentration of the normal saline. Where normal saline, can somebody tell me how much, Kavishka, how much sodium and chloride are there in normal saline, child?
The percentage is 0.9, madam.
Oh, මං sodium කොච්චරද potassium, sorry, chloride, sorry. Sodium is 154, isn't it? Hari? It is having 154 millimoles per liter. Okay. And chloride, of course, the same, 154 millimoles per liter. Let's say 150. Hari? Okay. So that is in a liter. Understand? So you can, there is a fluid called N by 2 saline, where this same volume is made into half concentration. Hari? So in that N by 2, you will have 70 or 72 millimoles per liter. Harida? Okay. So we call it n by 2. And එහෙම තියෙනවා n by 5 කියලා එකකුත්. Even though it says n by 5, it is like sodium divided into 4 වගේ තියෙන එකේ. So it has ඊටත් half එකක්. ඒ කියන්නේ 30 ගානක් තමයි ඒකේ තියෙන in a liter. Understand? So next time when you go to the hospital, please ask and see the types of fluids they have. They have normal saline. They have a half normal saline, we call it n by 2. They have quarter normal saline, or we call it n by 5. And ඒව තමයි saline ජාති. හරිද? We also have hypertonic saline, which is not, I'm not going to talk about it much. හරිද? Okay. So these are the types of saline. So all these are crystalloids. Okay. So why do you think that we have made n by 2 and n by 5 saline? Please answer. Otherwise, අපිට මේක ඉවර කරන්න බැරි වෙනවා. Yeah. It's okay. I don't know කියලා කිව්වත්. Tilina?
To have a hypotonic solution?
No. Hypotonic නෙමෙයි ශිහාන්. Hypotonic කියන එක not a good word because tonicity අඩු නම් the cell can burst නේ. So it is then now මෙහෙමනේ තියෙන එකක් භාගය කරනවා කියන්නේ ඒ තියෙන එක භාගය කරන situation භාගය දාලා ඕන situations, isn't it? Simple
Yes.
logic, right? ඒ කියන්නේ so දැන් අපිට sodium 154 දෙන්න බැරි situation එකකට දෙන්න. That is the situation.
Okay.
Okay, right? Logic, simple logic. හරිද? So that is to treat the, when you want to give fluids to a patient who is having ළමයා කියන්න, to give it to a situation to a patient, in a patient where the patient is having
Dehydration.
no dehydration. Anyway we need to give මං අහන්නේ n by 2 හදලා තියෙන්නේ කියලා child. n by 2 හදලා තියෙන්නේ to give it in a situation when the patients cannot be given sodium නේ වැඩිපුර. හරිද? එහෙනම් to what type of situations are those?
Hyponatremia.
Of course, the patient, if the patient is having hyponatremia, you can't give the normal saline because it has lot of sodium. හරිද? තව ඒගොල්ලන්ට n by 2 කරන්න පුළුවන්. එහෙමනම් n by 5 කරන්න පුළුවන්. Understand? Right? Because you want to give fluids, but the patient is already having sodium high. Also, this is a good fluid for who are the people who are doing pediatrics? Hello.
Diuresis.
No. Okay, we'll come back to it. Right, okay. So some situations where in pediatric situations also, you cannot load the patients with sodium. Right, okay. You all have finished, almost finishing pediatric appointment, isn't it? So why don't you do? Anyway, we'll come back to this later. Never mind. So then, so the people have made the n divided by 2, like half normal saline and quarter normal saline, to give into the situations like when the patients are having high sodium, or when it cannot be given that way, like in pediatric situations. Like I'll come back to the pediatrics later. So how much of sodium you need per day, Tilina? An adult man or human needs how much of sodium per day, you think? Anybody, please? ඇහෙන්නේ නැහැ. Kasun Chandra. Kasun.
1 to 2 millimoles per day.
Correct. Hari. So 1 to 2 millimoles per day. Harida. That is why when you make the normal saline, you made it that way in 1 liter. Easy, ne? Right? So say 70 kilo. Shehan kiwane 70 kilo kilo. If I happens to give the solution to Shehan, if I put 30, if I put say 50 or something in that one vial or 1 liter, then it's very difficult for us to calculate, isn't it? So people, I mean, this is how I remember this. The people who have done it and done it in such a way that it can be given easily. So ඒකෙන්ම මතක තියාගන්න පුළුවන් 1 to 2 millimoles per kilogram කියන answer එක. That's what the sodium requirement per day for y'all, right? So that is why sodium chloride solution has 154 millimoles per day in a liter. Harida. Okay, so that is a liter. What we see in the wards are 500 ml. Harida, one pint kila තියෙන්නේ 500 ml. Okay, right. So in that sodium 154යි නම් half normal එකකට භාගයයි quarter normal එකෙන් 4න් 1යි. හරිද? Okay, so these remember whenever whatever the time that you need to use it. But what do you think the children or the pediatrics need? Pediatric people need sodium. What's the sodium requirement per day?
3 to 4 millimoles.
Very good. They need higher ones, Chakasun. Very good. So they need higher 3 to 4. So even though අපි හිතුවට pediatrics ලට අඩු ඇති කියලා ඒකම කියලා එහෙම නැහැ. So they need more. හරිද? So then why did I say n/2 is for pediatrics? You can give in the pediatrics කියලා. That is because say අපි ගත්තොත් පොඩි ළමෙක් එයාගේ sodium requirement එක 2 or 4 millimoles per kilogram. But when we calculate his fluid requirement, then if you give it with normal saline, that we cannot handle, right? That is why n/2 is a good fluid to calculate and give to pediatrics also. Harida, like the situations like somebody said dehydration or we have to calculate and give, then when we are giving it, n/2 is a good fluid. Like that, n/5 is a good fluid for very small ones, neonates. n/5 if you give for the pediatric age group, they will have hyponatremia and they will die with the hyponatremia. Okay. Okay, right. So that is so then crystalloids කතාව දැන් ඉවරයි කවිෂ්ක. හරිද? Okay, so many crystalloids now we learned: normal saline, half normal saline, quarter normal saline, Hartmann solution, and now we have some more, right? We have like balanced solutions. Apart from the lactate, we have put acetate, and they have made the another solution. Now these solutions are being coming now, newly coming to the medicine to have it to the patients. Okay, so these are all balanced crystalloid solutions are there, where Hartmann's and these acetate solutions are balanced crystalloids, we call it, right? What are the colloids, you know? වෙන කවුරුද කියන්නකෝ answer එක? කසුන්?
Albumin.
Yes, very good. Now the colloids by definition are big osmotically active molecules. හරිද? So when you have big osmotically active molecules, then they can keep the water with them. Understand? So that is why they are called colloid solutions. So then they can keep the water with them, very big osmotically active molecules. So these osmotically active particles either has to be a protein or has to be a carbohydrate, harida, or like starch, right? So it has to be either a protein or has to be a starch product. So they have made, usually the proteins are animal origin, starch products are plant origins, right? So we have starch products like pentastarch, hetastarch. So those are the starch වලින් හදලා තියෙන colloids. හරිද? Proteins වලින්, or rather when you have proteins as colloids, those are gelafundin, gelafusine, things like that, which are having a bit of an animal origin. So anything which is new to the human body can mount allergic reactions, right? But out of the two, starch products may make them less allergic. So the pentastarch and hetastarch are never heard of any allergies. But for the gelafundin, gelafusine, people can come with allergies. Okay, so these are the colloids. So these are called synthetic colloids. They are made ones. So what Kasun said was natural colloids. So we have synthetic colloids and we have natural colloids. And the natural colloids are one such is albumin. තව එකක් කියන්න Kasun?
Blood.
Yes, very good. Blood. Why I'm asking, because I know the pediatric group was exposed to this teaching. Yes, albumin, blood, FFP, other cryoprecipitate platelets, anything can come in that nature. Harida. So that is the fluid, availability of the fluid of the colloids, right? Okay. Now, this is how so the selection of the fluid according to the nature of the fluid deficit and the presence of the electrolyte and acid-base disorders, you have to select the fluids. Okay, right. Then now what did we do up to now? Sorry, we have to assess the fluid amount, and then we calculated the thing, and then we decided what are the ways that it has lost, and also patient's electrolytes and acid base as well. So based on that, we can decide on what fluid we have to give. Now the fourth step is determine the rate of fluid administration. What is the rate we have to give the fluid? How fast to give IV fluids are decided on the basis of clinical assessment. And that is where somebody said no dehydration like that. So the grades of dehydration are there. So how fast we have to give is decided on the basis of the clinical assessment, because the acute losses should be replaced quickly, while chronic losses should be replaced with caution, because they have their regulatory mechanisms made for the body to have the way to handle it. So you have to be careful when you give for chronic losses, right? Okay, so then now I'm going to talk about selection of intravenous fluids in common clinical problems, right? Okay, this could be happening in the surgical ward, pediatric ward, gynae ward, medical ward, anywhere, A&E, anywhere, right? So I have decided these things because there are so many, but these things, all the things that what you are getting, right? Dehydration, as somebody said, or it could be due to diarrhea or vomiting. And it could be either diarrhea only, vomiting only. Harida, okay, so that cannot be the same thing. Then because the loss of fluids and electrolytes in diarrhea is different to the electrolyte loss in vomiting. For an example, vomiting reduce lot of chlorides, but diarrhea may be something else. Okay, we'll talk about it, right? And a patient can come with blood loss, nothing to do with these two, can come with simply blood loss, like we just learned about the trauma and the bleeding. Also, they come for surgery. So during surgery or post-op, this is a different type of loss. This must be a lot of things. Say if they open a tummy which has an ascites, they lose it in a different jatia. Understand? So like that. So the things are different in surgical things. And then also in the post-operative period, it is a different one. It can during post-operative period, what could be the fluid loss. So I'm going to go in these lines. Okay, right. So also we have special situations. So apart from these clinical problems, there are special situations like hyponatremia. The patient is having hyponatremia. So we have to have a patient who is having a dehydration probably and hyponatremia. Or there can be a patient who is bleeding and can hyponatremia. There's a patient who has vomiting and have hyponatremia like that. So fluid therapy in hyponatremia, you need to know. Fluid therapy in dengue, right? Or the dengue. And because now in medical wards, you need to know that if the patient is having dengue. So these are the special situations, right? Fluid therapy in hepatic encephalopathy cannot be the same in renal, right? So fluid therapy in hepatic encephalopathy should be a different one. Fluid therapy in initial phase of stroke could be a different one. Fluid therapy in burns is a different one. Fluid therapy in pediatrics is a different one, right? So I'm not going to go one by one. But if you know the basics, you should be able to select the appropriate fluid for the each situation, right? Okay, let's see how. Okay, so then now about the dehydration, somebody was talking. Yes, how much fluid to give in dehydration? Okay, so always you have to calculate the percentage of percentage. This is not presentation. Oh, okay, presentation of dehydration with the percentage loss, right? Okay. So we have three things, three dehydration stages: mild, moderate, and severe. Okay. So when it comes to mild dehydration, we say up to 5% of the total body water is being lost. Harida. So how much, what is the normal or total body water in anybody, Lamai?
60% of total body weight.
Okay, very good, Kavishka. Etakot Kavisha, anyway, then what is in your body? Harida, how much of water is there in your body? Volume?
38 liters.
No, you must be having about 42 liters. Harida? Okay, yeah. ඒක කොහොමද distribute වෙලා තියෙන්නේ?
2/3 of that is intracellular fluid.
Very good. And
1/3
1/3
is
in the in the
interstitial.
whole extracellular fluid. හරිද?
Yes,
1/3. එතකොට ඔයාගේ අපි හිතමු 40 liters කියලා. 40 liters වලින් 25 තියෙනවා intracellular නේද කවිෂ? එතකොට
Yes, ma'am.
15 liters තියෙනවා extracellular. So ඔයා නිකන් bloated up balloon එකක් වගේ නෑනේ. ඔයා නිකන් barrel එකක් වගේ නෑනේ. එහෙම නෑනේ. Huh? So you are nicely distributed in your compartment. So 25 liters are inside your cells, mind you. Lot
Yes,
of volume. Harida. Okay, it's such a creation. Then 15 liters extra to that cells. So how much is in the, now that is being distributed in what compartment, Kavishka?
The plasma and the interstitial
Very
fluid,
good.
madam.
The plasma and the interstitial. Very good. Blood walai, interstitial walai. So interstitial meke kiyat tinada plasma, blood wala kiyat tina. Blood wala. Blood. How much of volume you have it in blood, Kavishka? Just guess. Anybody?
5 liters.
Kaude,
Five.
Tamachai?
Tamali.
Okay, Tamali. So now, say Kavishka, oyage Kavishka weight take 70, I think, right? About Shahani's size, I remember him as 70 kilogram child. Now he's having his total body volume එක කීයද Tamali?
Body water.
නෑනේ blood volume එක.
42 liters.
Blood volume. දැන් ඊයේ කියලා දුන්නානේ. Blood volume.
5,000.
Yeah, 5,000. That is 5 liters නේ. එතකොට that is blood. හරිද? දැන් මං ඇහුවේ කවිෂ්කගෙන් එයාගේ blood වල තියෙන water කාණ කීයද කියලා, or the fluids. That cannot be the 5 liters no child then. The whole blood is 5 liters. Harida. Okay. So then the blood has cellular compartment and the water compartment. Harida. So how do you know what compartment is what kila? How do you know? What is the measure? What is the measure to say this is the cellular compartment, this is the water compartment? Anybody?
Hematocrit.
Very good. Excellent. Hematocrit. The hematocrit will tell you how much of is that is fluid or the cell. Cell they normally can. එතකොට packed cell volume. හරිද? So that is to say how much of that is in the cellular compartment. It roughly comes under the 30-35 එහෙමනේ ඉන්නේ. So 1/3 තමයි එකෙන් ඒ කියන්නේ තියෙන්නේ fluids. හරිද තමලි? So out of the 5 liters, right? 1/3 විතර තමයි fluid. Sorry, 2/3 විතර තමයි fluids. 1/3 is cell. හරිද? Okay, blood cells, red blood cells, white blood cells and all, right? Now, if I take Kavishka, who is 70 kilos, having 5 liters of blood, how much roughly do you think plasma contains as water? Plasma. Roughly comes to 3.5 liters. Harida. So, if I take Kavishka, Kavishka is having 40 liters, 25 liters inside the cell, roughly inside the cellular compartment. 3.5 or 3 liters, let's say, in the vascular compartment as plasma, and the rest, like 12 liters, is in the interstitial space. Okay, Kavishka, right? So, yanika vatura puropu balmak wage tamai. Hari all of us, right? Okay. So, what is the importance of having this interstitial fluid? Why do you think that people are having interstitial fluid? There should be a reason why. Yes? Anybody?
Diffusion of substances.
No, Ravindu. Diffusion of substances, it is true. But why do you think it is there? Okay, you mean the from the vascular cell diffuse vendada?
Yes, ma'am.
Yeah, you can say that, but you don't need 12 liters for that. Why 1 liter? You take just put 1 liter. Why did he put 12 liters?
To maintain a stable cellular environment, madam.
No. How? No, that is in a situation where you need more fluids in the body to take that fluid back. Understand? Tell me a situation where you need fluids in the body. Trauma.
Dehydration.
Trauma, we just said no. Yeah, it could be dehydration, it could be trauma, vela bleed, vela hemorrhage. So there could be hemorrhage, there could be dehydration, there could be many things where the body needs fluids, right? So hamma vela ogala mage doctor line or the fluids then. එහෙම නැත්නම් එයා වතුර ටැංකිය ළඟ ඉන්නවද වතුර බොන්න? නෑනේ. So the body has is what is called, these are called the homeostatic mechanisms in the body. The homeostatic mechanism for fluid also there. Understand? So the interstitial fluid is like a buffer, right? So when the body needs, they will be coming back. Certain percentage will be coming back to this. හරිද? And I am 2000% sure මේ කෑල්ල උගන්නලා තියෙනවා මමම කියලා. හරිද? Okay. So මොකටද මේක ඕනේ? මොකෙන්ද මේක අපි ගන්නෙ? කවිෂ්ක මට ඔයාව නම් හොඳට මතකයි මෙයා කරේ integrated modules වල එහෙම කරලා තියෙනවා. Yes. What is the mechanism? They take the interstitial fluids and all back to the fluids compartment, or rather vascular compartment.
Starling forces.
Excellent. That is why. So use of the Starling forces and all. So now can you remember when we learned about the hemorrhage in class 1, they didn't drop the blood pressure?
Yes,
Remember? Right. Even in class 2, they vasoconstrict and increase the fluid status and all, they were trying to maintain the cardiac output. Can you remember?
Yes, ma'am.
Right. So this is how it is. So this is like a buffer. This is a beautiful creation, right? Okay. So these are buffers, right? Anyway, so now so then now when they are there only, also the patient can go into dehydration. And now I'm going to talk about the dehydration. So there's a mild dehydration, moderate and severe. And we say 5% of the total body water loss is mild. 5 to 10% loss is this. And my volumes because make a podi lamine to make easy. 5 to 10%, and 10 to 15% of total body water loss is called the severe dehydration. And we cannot go more than this, and the patient will die because that amount of brain cells go into dehydration, and then after that, not much of function. So mild, moderate, and severe, right? And remember, mild 5%, moderate 5 to 10%, severe 10 to 15%. If it is an adult, make alvenai. If it is an adult, 3 liters about in 70 kilo, 5 liters, giham api moderate kena, 8 liters idhar giham severe kena. This is for children mainly. Okay. Okay. So we say, but then patients will not come and tell you that make situations will manage karanna thiyena fluids are different. So each situation needs to be managed in a different way. Okay. So for mild, the patient will not come and say, doctor, I have mild dehydration, so manage me as the mild dehydration. Just like your shock status, then you need to identify the shock. Like that, he won't come and say, doctor, I have moderate dehydration, can you please manage accordingly? Doctor, I have severe dehydration, please manage me. Right? We need to know what is the percentage of dehydration they have. They will only come and tell, vomit kara, diarrhea tibuna, and all. Right? Okay. Okay. So the how do we know that? So when the patient comes like this with a normal mental state, but dry mucous membrane, usually they complain of thirsty, and the blood pressure, heart rate normal, but little bit of lower than normal urine output, and skin turgor almost normal. Now these type of people, even though you think they are having dehydration, they are having a mild dehydration. The ඕගොල්ලෝ මේ stage එකේ හිම ඉඳලා තියෙනවද lectures එනකොට ළමයි කවිෂ්ක honesty. Honesty.
Yes, ma'am.
මෙහෙමනේ ඉන්නේ වැඩිපුරම නේද?
Yes,
නැද්ද?
ma'am.
ඒකනේ. It is not to be done. You all are dehydrated, including me. හරිද? I am also coming into the same category because I finish my list and come running to the lectures. And when you all are not there, then can you see why we get upset? Because we also coming with dehydration, right? Okay, so please don't. Whenever I do this lecture, I always see some people put their hands into the bags and drink their water bottle from their water bottle. Right, anyway, so mild dehydration. When it goes to a little higher level, then the patient will be disoriented or disinterested in the surrounding, can be drowsy, increased heart rate like the class 2 shock, heart rate and the respiratory rate, orthostatic hypotension, decreased skin turgor, and reduced urine output. So these are the situations where you know this patient is not mild, it is sort of coming into the moderate dehydration. Harida. Okay, so you should prevent them getting into this because you have only one stage to go to die, right? And especially in a very small children, this is the stage they have this frontanels dip when frontanels dipped, or rather depressed fontanelles comes in this particular percentage. When they are severely dehydrated, they reduce the conscious level, very fast heart rate, very low blood pressures and respiratory distress and oliguria or maybe anuria. So when the child is being brought thing, vomiting and diarrhea, makina, doctor, this child had vomiting and diarrhea. So you have to say, is he now crying. So that is showing he's irritable, right? Or he can be drowsy, right? Okay, so when you check the heart rate is very high and the blood pressure is, and he's so highly breathing, respiratory rate, right? So then skin color, then all these we dry them මේ ටික ඔක්කොමත් තිබිලා තමයි මේක එන්නේ. මේක තිබිලා තමයි මේවා එන්නේ, right? So dry mucous membranes, sunken-eyes, fontanelle එකත් පොඩිම නම් fontanelle is dipped, and yeah, සම්මා බබා urine pass කරාද? Did he pass urine? How many pampers you use? නෑ doctor අද pass කරේම නෑ. ඕ පොඩ්ඩක් pass කරා doctor කහම කහ පාටයි, and all you know that now, right? So this is how you gauge the dehydration. If the child comes diarrhea and vomiting, drowsy, and then you feel the heart rate is very tachycardic, very tachypneic, and the pressures were low, and amma urine pass karada baba ne doctor ada dawasatama giye ne. So you know that you all are handling a severe dehydration. Okay, right? Okay. So the method of assessment of body fluids is at the patient's daily then now. Oh, sorry, this should be the previous lecture methods. So make at the patient's daily maintenance requirements to the fluid needed to replace the losses to make the total daily requirement. So now say you get a 5% dehydration child. So you have to have, this is called the deficit, right? Already it is being deficit of what the patient should be having. Now when you want to prescribe the fluids to this patient, you have to put his normal requirement, the maintenance and the deficit. Understand? This is also the same, the normal requirement or the maintenance and the deficit. Maintenance and the deficit. So you have to have that. So how do you calculate the maintenance by any chance, if anybody knows? The maintenance fluid is being calculated for children, of course, with the equation. ඕගොල්ලන් පීඩියට්‍රික් ඉවර කරන්න ළඟයි නේද දැන්? කවිෂ්ක ගුටියක් දෙන්න වටිනේ කට්ටියටම. මේ නම් මෙනාගේ නම් විතරයි මම කියවන්නේ. Sorry, I'm always referring you, a few of you. Yes, how do you calculate fluids in pediatrics? Have you learned how to calculate fluids in pediatrics? Kavishka, are you doing pediatrics?
No, madam. Psychiatry.
So tell me somebody who is doing pediatrics. Or even surgery, somebody is doing surgery, how an adult you have to calculate. Or even medicine.
100 milliliters for the first 10 kilograms. Then it will be 50 milliliters per kilogram. For next up to 50 kilograms for the next 30, you can calculate at 10 milliliters per kilogram.
Oh, next 30 next all. Okay. So first 10 kilograms. So what's the name of that formula, child? Holiday. Okay. Halliday's formula. So it comes with the 10 kilograms. Yes, correct. So 10 kilograms. So later you put first 10 kilograms. We put 100 ml. But this is for the 24 hours. The second one will to 50 ml. ඊට පස්සේ ඔක්කොටම 20 ml per kilogram. හරිද? Okay. So if you do it in an hourly basis, you take 4 to 1. First 10, 4, 2, and 1. So we call it 4 to 1 regime or Halliday formula for this. හරිද? Okay. So that is called the maintenance. And adult, how do you get the maintenance? It is you take 35 milliliters per kilogram. Just like the calorie requirement. So say if it is Shehan, because I take Shehan because he told me his weight yesterday. So it is 17 to 35. Harida Shehan? That is the volume. 70 into 35 key the volume per day requirement, Mr. Shehan. මොකක්ද නේ යාගේ surname එක ෂා?
Around 2,500.
Okay. So, yeah, Shahan Udekuma. Yes. So, yes. So, you need about 2,500 ml per day. Then, honestly, මට කියන්නකෝ යා ඔක බොනවද කියලා.
නැති.
ඒකනේ. ඔයත් නෑ මාත් නෑ අපි කවුරුත් නෑ, which is wrong. Right? Okay. But when the patient කෙනෙක් වෙන එක හොඳයි. මොකද අපි ගණන් හද දෙනවා. හරි? So, you need to have, that is the maintenance. And if you come with moderate dehydration, or if a child comes with any sort of dehydration, that needs to be added to the maintenance. That's what I'm trying to tell you. Right? So watch carefully. Then you have to add the patient's daily maintenance requirements to the fluid needed to replace the losses to make the total daily requirement. And we have to watch carefully for a response to IV fluids and modify volume and rate of fluid infusions if necessary. And every patient responds differently to fluid therapy. You must remember that, because now every patient doesn't be the same. Heart venas. Okay. So I said I love to talk about the sodium. So sodium concentrations in various fluids, if you if it is isotonic saline, it is 154. It is Ringer's lactate, it is 170. This is what I told you, n by 5, then 0.9% කිව්වනේ කවිෂ්ක ඉස්සලා. So 0.9% දෙකට බෙදුවනම් 0.45%, right? So the millimoles of milliequivalents or millimoles both equal in sodium is 77, half of it. හරිද? Say if you take 3% sodium chloride, which is also, I told you, hypertonic saline කියලා જાතියක් තියෙනවා කියලා, that is having a different එකක්. දැන් ඕක මතක තියාගෙන ඕක කටපාඩම් කරන්න එපාය. හරිද? At least remember this. Okay. Okay. So the potassium concentration, again, in normal saline, you don't have potassium, but Ringer's lactate, you have a little bit. And if you have neat KCl, you have a lot. Now, this is not the fluid. This is, I'm just trying to show you an ampoule of KCl has this amount. So you don't need to worry of it. This is in a liter. So you don't need to worry. This is in a 10 ml. So this, if you give, if you really want to kill somebody, the easiest is to give a KCl, right? So don't give that. Make it 1 liter යන්න ඕනේ මේ ගානේ යන්න. So you don't need to worry. Okay. So මේ දෙකම එකට දාන්නද මේක? Looks like නේ. Yeah. Potassium concentrations of intravenous fluids අද ඒවවල. There are, I told you, there are now new balanced solutions are coming. Say Ringer's lactate has this. You're seeing my cursor neither. Shehan, are you seeing my cursor here? When
Yes,
I'm showing? Yes.
Yeah.
So the Ringer's lactate have 4. And we have these solutions, isolite M, isolite P, isolite G. Now we will be getting these fluids. Actually, we have isolite M already. So we have a lot of solutions like this, isolite M, P, G, things like that. And now we are having different solutions. Okay. So these are called balanced solutions. We have the Ringer's lactate already. And we have Ringer's, we have with acetate as well. Okay. I put that also. So the selection of intravenous solutions for initial treatment of hypovolemic shock. So you now this is this is it. Then now I am talking about the hypovolemic shock. Harida, okay. So the hypovolemic shock, we have no place for 5% dextrose. Harida, I earlier කවුරු හරි කිව්වා නේද crystalloid එකට මේක, right? And I told you it doesn't have any electrolytes. So, but still 5% dextrose is simply dextrose and water. Understand? So, in situations where I can use this is where if you give sodium, say if you give sodium chloride to patients, let's say you give normal saline to a patient. What happens here is when you give it, you put a cannula and give it to the IV. So only 1/3 is going to stay in the in blood. 2/3 will be going to the interstitial compartment because it is the electrolyte is almost isotonic. So only 1/3 is going to stay in the interstitial compartment and 2/3 will be going to the intravascular compartment and 2/3 will be going to the interstitial compartment. Understood? Right. Now in dextrose, it is not only leaving from the vascular to the interstitium, they go intracellular also, right? Which is not really great in situations of hypovolemic shocks, but certainly in some situations only. Right? So, but nothing is going to be left in the intravascular compartment. Now, when the patient is having shock, that's where you want the fluid, isn't it? We don't want the fluids to be loaded in the interstitial or in between the compartments. So that that is giving a negative impact. So it should be avoided in shock. Harida. So any shock patients, like what I told you, like hypovolemic shock seen yesterday, අපි කතා කරේ trauma වල. So ඒගොල්ලන්ට අපි fluids වලට dextrose දෙනවද? No. We give either normal saline or Hartmann's. I told you yesterday. Remember? We are not giving the dextrose at all. Hari? Neither this isolate fluids that I told you, මේගොල්ලන් දෙන්නෙත් නැහැ, because they are also highly not indicated in hypovolemic shock. So the most effective agents are either crystalloids, but you know 1/3 tamai TNA, 2/3 goes, but you can still give crystalloids. But the most effective ones are colloids, right? Why? Because if you give 500 ml, they'll stay there, right? 500 ml must stay there. Interstitium, intravascular compartment, they are going to stay. They are not going to the interstitial compartment. And that's what we need. We need the cardiac output to go. So that is why the colloids are very important. But when I say colloids, it could be a synthetic colloid, it could be a natural colloid, right? But we all know natural colloids like blood, denalbumin, all these can mount reactions, isn't it? Because they are not your ones, so they can mount reactions and they have a lot of other complications. So for a very small percentage of blood loss or the hypovolemia, you can try with only with crystalloids. How much of crystalloids to give? The assessed volume into 3 times, because 1/3 thamai is going to stay inside the intravascular compartment, 2%, 2/3. So if you think there's 500 ml loss, you give 1500 of crystalloids. Done, right? No reactions, nothing, cheap, nothing. Okay, everything is good, very cheap, no reactions, no problems. Cannula, 3 times of what you think the loss of crystalloids, normal saline or Hartmann's, done. Okay. If the patient lost so much of blood, right, and go into stage 2 or 3 shock, right, then how much to give as a crystalloid? 3 times of the loss, huge volume. So how much to give like a basin to putting is a problem, because most will be end up in the interstitial compartment, and as somebody said, microcirculations, micronutrients, nothing will go to the cell because it's loaded, drowned with water. So you go with colloids, right? And this time you can reduce the volume of giving, because if you think 1500 or like 1400 loss, you give the same volume with that, right? Okay, so then now what colloid to be used? You want something which is not going to react to the patient, so you go for starch, because we just learned that has less reactions. So the starch to be given, but people have put a limitation for the starch per day, like 1000 ml in Sri Lankan weight sector. About 1500. So 1000 only goes with that, and the rest will be going with the crystalloid. Harida. Also, if it is a huge blood loss like grade 3 shock, then you can't be just giving crystalloid base. You can't be huge volume of crystalloid, neither colloid, because you are limiting with 1000, and here that's where you have to give the blood. Okay, understand? Done. And if it is more than 40%, it is definitely blood and not ting. It has to be given fast, right? As early as possible. And that is where your O negative comes in. Okay. All right. Okay. So the most preferred fluid in the hypovolemic shock is isotonic saline and rigorous lactate in early stages. Okay. Good. Terunadani? Did you get the points, Kavishka?
Yes, madam.
If not, please ask. Even though I said that, that's one of the most important things that in this lecture. That's why. So how do you know that your monitoring of the status of the fluid is whether it is lost or corrected? Even both stages, monitoring of the fluid is done by clinical measures like skin turgor, temperature, peripheral temperature. So even we know if the perfusion is very low, patient will be cold, neither peripheries are cold. So that's a good sign. Pulse rate and volume, we just learned yesterday. Pulse rate, volume, blood pressure, and not only, sorry, make it blood pressure, systole and diastole, and the pulse pressure. Yesterday, somebody was talking about the pulse pressure. And one of the other very important thing is the capillary refill time. And let me ask you all, one of you can tell me, how do you check the capillary refill time? How do you check the capillary refill time? Tilina.
You push on the nails of the patient and see how long does it take to coming back to the normal pink color.
Push. So you just push, Mema, tick, and then see in a minute. In a minute. Yes, Tilina, you can try. Press, coming back. That says I am well perfused. Sachini.
Press the finger and count for 5 and then
Yeah, so very good. So you have to press for some time. හරිද? ඒකට හරියන time එකක් තියෙනවා. හරිද තිලිනා? You cannot just press
Okay,
නෙමෙයි.
ma'am.
You have to press for some time. You have to empty this nail bed. හරි? So you have to press it and say 1, 2, 3, 4, 5 as Sachini said. Understand? So 1, 2, 3, 4, 5. Then it is empty and then relax to see how fast it is filling. At the Sachini, if it is a normal, nicely perfused patient, how fast it should fill?
less than 2
seconds.
Madam?
Yeah, within 2 seconds it fills. Very good. Right? 1, 2, fill. Pink. Right? Okay. I press 1, 2, 3, 4, 5 and wait. 1, 2, 3, 4. There it comes. It's so delayed. That is to say, the volume is less. Harida. Okay. So that is to say the volume is less. Haride. So blood pressure, pulse pressure, capillary fill time, CVP, if central venous pressure, if TNR, urine output. So these are all clinical and the other measures to check the volume status of the patient. Harida. Okay then, right? So I'm going to now turn into a different angle, which is the fluid balance during surgery, right? Okay. So how are you going to get the fluid balance during surgery? Obviously, we need to see the maintenance of the fluid. And then the deficit, the patient can come with a deficit. Say if the patient has had an intestinal obstruction, they can come with a deficit. Or the patient had a dehydration, they can come with a deficit. If the patient had a trauma and bled, they can come with a deficit. Harini? Okay. And then we all know the patient needs the maintenance. Whoever comes, say Sachini goes to a surgery, she needs the maintenance according to her weight, right? And also ongoing losses. So the surgeon needs the doctor. So then the bleeding, and then it needs to be got into the swabs, and then the suction apparatus in his body everywhere, the bleeding. So the blood loss has to be counted as an ongoing loss. NG tube gastric aspirates, fistulae, drains, everything can be counted on the ongoing loss. And there's another one called third space loss, where they don't know where it is being lost. Some loss is there. So now what we do for third space loss is we calculate it. And major surgery kilo ekakata. For intermediate surgery, for this kilo amount, this is what the loss. So like that, the third space loss is being calculated according to the surgery of the intermediate or major. And also when the body is open to outside, then all the bubbles are open. There are so many evaporated. You don't see that. So that's also is being counted 200 ml per hour, like that you count it. Okay. So remember, we count the maintenance. We have to give the deficit the patient comes in, and the ongoing losses by blood loss. So you can measure it with the night suction bottle. The bleeding, the SOBSA needs to be counted, or maybe weighed, or something like that you have to get. And the other volumes you need to see, right? Okay. Some people for fluid balance during surgery mention urine output. Harida, that is not to be replaced. That's the way you know you are giving enough. Understand? Because it is here. Harida, clinical one is here. Harini, so it is not to be given unless it is very high, like, you know, for the neurosurgery and all, you have given some mannitol or something and the patient is passing a lot of urine for a reason, then it has to be replaced, but otherwise it doesn't need to be replaced. That's the way we know the fluid balance is right. Okay. Okay, so we all call it a blood loss when the swabs, we take it like, you know, large, big swab, it is 80 ml, and a small, tiny one, 5 ml or maybe 10 ml, and the suction and the spillage. So you have to then calculate all blood loss, and now you know how much of loss, you know the percentage loss, so you know what to be given. Say if it comes to more than 30%, you have to replace with blood like that. And in the aspirate, you have to calculate and you have to give it with saline or Hartmann's. an acidic fluid, like acidic bandiya kapala enne ekaparama. So that has to be given with a colloid. Say if the patient have ascites and then you open the tummy to do the surgery, they lose a lot. So that's a colloid, and you have to give with colloid. You have to give with FFP or something, or maybe Hartmann's. Okay. Okay, so the third space I told you, a leak of fluid to a hypothetical space. That is why you call it a third space, due to the damage of the blood vessels in the tissues, not due to physiological forces. So then this has to be counted. Like if they go for major surgery, it is 15 ml per kilogram per hour. To be honest, I take little less than I take 4, 6 and 8, right? But this fluid not lost from the body, and remember they are just being hidden in some space. That's why it's called the third space. And the second post-op they are coming back. So it has to be, it is not lost from the body, and it will be excreted 3 to 4 days after the cell membrane repair. So that is why I go for a little lower, because I know in the ICU I have to struggle with this volume, right? Okay. Okay, somebody yesterday nicely told me, how do you estimate the blood loss? Somebody said that depends on the surgery. If it is, if I remember right, it is Tilina, somebody said. Ne? So yes, I said yes, because the fracture femur, this is the volume of loss usually. You lose about 0.5 to 1.5 liters. Fracture pelvis, you can lose about 2 to 4 liters. So if you know there is a fracture femur or fracture pelvis, other assessment also needed, but you can guess the volume of loss, right? Okay. So in hemorrhage, and this one we discussed this very much yesterday. Let me reiterate again. Say for the CNS, it is alert. Patient is alert for the 15% loss of this is Shehan, which is who is having 70 kilos, healthy boy, and this one, this amount of loss. And the CNS, he will be alert, and pulse, it's about 100 and less than 100 rather, right? Blood pressure, both systole and diastole normal, capillary refill normal, and respiratory rate is normal, and urine output is normal, which is more than 0.5 ml per kilogram per hour. And this is how he comes, and you have to diagnose, and you have to diagnose the loss, and your management is only by the crystalloid, right? Why I now just a minute ago discussed. Shehan, can you understand?
Yes, madam.
Good. Then others also can understand the because not much of time make a book right? So if the patient comes with say anxious, and then if you check the heart rate it's very high, more than hundreds, and then systole is little normal, but the diastole is increased, so your pulse pressure is low, remember, and then the capillary refill, it is more than 2 seconds, right? So that's delayed, and then respiratory rate is 20 to 30, so tachypneic. Urine output is marginal, it's dropping less than 30, but you know the patient's, the pathognomonic is his mentum and his diastolic pressure with a high heart rate. So you know he has lost about this amount, and now you cannot only give crystalloid, you have to add crystalloid to that, you have to add the colloid. But when you're adding colloid, say if you're thinking of 1500 make 1005. So if it is to 1005, you cannot give 3 times of that with crystalloid. So you give about 1000 colloid, because you have a limitation of 1000 colloid, and the rest with crystalloid. Understood, Tilina? Understood the Tilina?
Yes, madam.
Good. When the patient comes with very confused or maybe a bit of a lethargy, and a volume of pulse is very low, 3D, the systole is dropped, the diastole is dropped, both dropped, very low, and the capillary refill time is very delayed. It's even more than, make a 3 to 5 with Ravino. And the respiratory rate is very, very tachypneic. He's breathing. The urine output is very low, oliguria. And now his estimated loss is 30 to 40%, which is coming around 2000, 2000. And now you know you cannot try only crystalloid. You cannot try only colloid either, because there's a limit. And also there's a huge volume of blood loss. So you have to give blood. This is bleeding, not dehydration. Harida, did you understand this, Sachini?
Yes, madam.
Okay. So this patient needs, this patient needs blood and crystalloid and colloid, all. Crystalloid and colloid definitely, but definitely blood. Harida. Now here, will you be having blood cross match කරලා ගෙන්න ගන්න time? You might, right? You might have time to get the cross match blood, but might not as well. So එහෙම වුණොත් O negatives දෙන්න ඕනේ. එහෙම නැත්නම් group specific. එහෙම නැත්නම් වෙලා තියෙනවා නම් cross matched, right? When it අයියෝ මගේ පින්තූරින්ලා වැහිලා. Okay. Right. So when it comes to patient is very comatose, right? And then the very thready pulse and very faint, and the diastole systole ඔක්කොම dropped හොඳටම ඇහෙන්නෙත් නැහැ, පේන්නෙත් නැහැ. Capillary refill එක හොයන්නත් බෑ, it's so cold, and then the respiratory rate is very high, and he's and the urine output is almost nil, right? And now that is to say he has lost more than 40%. There should be a sign of more than 40% here, and that is to say more than 2000 loss, right? And do you understand this is a life-threatening situation? So there's no more but the blood, and it has to be given very fast. And this is where your O negative is very helpful to you, right? Okay, done, understood, Kavishka?
Yes, madam.
Good, right. So now you know. Yesterday I told you I'll be discussing about this tomorrow, right? And this is what I was discussing now. I did. Okay. So remember the blood transfusions, you have to accept the lowest transfusion triggers, like young healthy people like y'all. I can accept the loss of 30%. I won't give the blood loss more than, if you don't lose more than 30%, we won't give you blood because it has a lot of problems. And for average health people, again 20%, you better give some blood. And poor health, even 10% of blood loss, you might have to give blood. And HP targets are this. Young healthy, we can wait till you drop even the HP to 6 or 8, maybe 7. Average health also 8 to 10. Poor health, like somebody's grandmother who has an ischemic heart disease and very frail, even a little bit of blood loss, we might have to give the blood. Okay, right? So it depends on the individual also. Selection of intravenous. Okay, why do we avoid the 5% dextrose in shock status? It is ineffective in raising blood pressure. That is, I just told you. It carries risk of hyponatremia. Why? Because it doesn't have any sodium. It leads to urinary fluid loss, where large and faster infusion of 5% dextrose will lead to hyperglycemia and osmotic diuresis. So that's not good. Disadvantages of osmotic diuresis are it delays the correction of dehydration. So we don't know. It misguides the clinician by creating false impression that there is satisfactory correction of deficit. In such setting, rate of fluid replacement may be reduced despite hypovolemia, and this can be detrimental. So you better not give the dextrose in the situations of severe shock, because some more with that hyperglycemia by the urine. Avoid all isolates like isolate M, P, G, because they are all having potassium and poor sodium and high potassium. So you should avoid these. So you don't need to worry because we don't have those. And most preferred isotonic saline because it corrects the hypotension effectively. So 1000 ml will increase the intravascular volume by at least 300 because others will go out. Safe even when glycemic status is not known. Advantages of saline over the colloids blood products are less cost, easily available, and no risk of reactions forever. So that is why one advantage of saline. And the preferred fluid is Ringer's lactate because it corrects the hypotension effectively. So 1000 ml dunanan, at least 300 ml will be staying. Most physiologic composition of Ringer's lactate is similar to extracellular fluid. Like Kavishka said, it has potassium, right? If patient needs more than 3 to 4 liters of normal saline, it carries the risk of expansion acidosis. So if you happens to give a lot of crystalloids, don't give it with saline because it causes acidosis. And in that situation, Ringer's lactate should be the best choice. Okay. Say for an example, vomiting and gastric drainage, you lose a lot of potassiums and chlorides. So better to give with Ringer's lactate. So the most effective agents in this hypovolemic shock is the colloids, albumin, and I just discussed that. Okay, rise in intravascular volume. Invasive methods. So I told you by clinical methods how to check the volume status, but we have some invasive methods also to assess the body fluids like central venous line. So the people who come to the appointment will see. arterial line invasive blood pressure monitoring, cardiac output monitors, people who go to the cardiac theaters like we have grouped, and tonight we will be telling you which theater to go and you will be seeing this. And pulmonary artery catheter is not much available these days, but I just wrote it. It is a correct answer though. So at the patient's daily maintenance requirements to the fluid needed to replace the losses to make the total daily requirement, and watch carefully for a response to IV fluids and modify the volume and rate of fluid infusion if necessary. Every patient responds differently to fluid therapy, that has to be reminded. So whenever we give, we should not forget the fluid volume excess as well, because that may be a problem. Most of the time, ICU in a fluid volume excess sometimes because they just being given. So what are the signs? Tachycardia, increased blood pressure. Even though I wrote it, it is not much. Because if they goes into failure, none of these are there. And edema, weight gain, orthopnea, distended neck veins, gallop rhythm, that is because they are going into heart failure. Pulmonary edema mainly, ascites, pleural effusion, these are all not much. So I would say these three are the main things. Others are a bit of a chronic ones being given fluids, right? So this one is the characteristics of intravenous fluid. So I've just discussed this, like, say if you take most physiologically ringer's lactate, right? So I would say out of the all, what is the most physiological? Ringer's lactate, because that doesn't have any glucose also, and this is the rich in sodium is normal saline and these things. Rich in chloride, this. Rich in potassium, this. I've discussed all these things, right? So the fluid therapy in diarrhea is diarrheal fluids rich in sodium, bicarbonate and potassium. So the diarrhea leads to hypokalemic, hyperchloremic metabolic acidosis. Why? Because it's a dehydration. So most of the patients with diarrhea-induced dehydration can be treated effectively with ORS. Few patients with severe dehydration and shock need IV fluid therapy. Okay, why? Because if they are on the 5 test more than 10% dehydration. So the good fluid is a Ringer's lactate is most preferred. Why? Because they have lactate and they have additionally provide the bicarbonate. So in severe form of diarrhea with acidosis and hypokalemia, that also being handled with the Ringer's lactate, right? So that is why it is a fluid of choice. If only metabolic acidosis is corrected, then it should be different. Potassium will be shifted intracellularly, so you don't need to worry about this. So if you just know in the fluid in diarrhea is Hartmann, that is enough. Okay. Fluid therapy in vomiting, because they lose hypokalemia and hypochloremia also with metabolic alkalosis. They go into, this man goes into metabolic acidosis mainly with dehydration. This goes into metabolic alkalosis mainly. So most preferred IV fluid to correct dehydration due to vomiting is isotonic saline, right? So the saline prevents further loss of potassium and effectively corrects the rest. Say prevents, like it's not making it potassium, but prevent the loss being correcting it. To restore the previous and ongoing potassium losses, you can give another potassium, like so. You can put the saline and add the potassium separately, right? Add the potassium to the saline, so that will be more saline. You need more potassium because a lot of potassium is being lost, right? Okay, and you can try the isolate G, but you don't worry, these things are for postgraduates mainly. So in vomiting, if the patient comes to me with dehydration, I will give the sodium with added potassium. Harida. And combined loss of diarrhea and vomiting, then I would go for Ringer's lactate because that will correct both, right? Okay. Fluid therapy in hyponatremia, because the hyponatremia is the most common and frequently missed electrolyte disorder. So in all patients receiving maintenance fluids, you have to measure the sodium concentration daily to prevent the hyponatremia. So all of ICU patients are measuring, we are measuring the sodium daily. And completely avoid all hypotonic fluids in patients whose serum sodium concentration is low. And that is where your you shouldn't use N/2s, N/5s and all. So acute decrease in serum sodium concentration below 125 is not good, no? They have the neurological symptoms and it is considered as a medical emergency. They can fit, they can lose the consciousness, many. And you have to controlled correction of sodium has to be done. If you just give dada sodium, then they go into pontine demyelination and they'll have more problems than having low sodium. So you have to control correction. You only have to increase 2 millimoles per hour or something like that. It shouldn't be very fast. But rapid correction of chronic or asymptomatic hyponatremia can be detrimental. So you have to be very careful of correcting hyponatremia. You better correct the dehydration and correct the hyponatremia very cautiously. It is more than 8 millimoles per liter per day. Around that, around 12 millimoles per day we increase. You have to rule out the pseudo hyponatremia. I'm just telling you this. The hyponatremia can come with dehydration, and hyponatremia can come with hypervolemia. Okay, so this is called then pseudo because it is not hyponatremic, it is because hypervolemic they will be shown here. So I'm not, I don't think you will be asked on this particular type of disorders in your final MBBS. This is little too much for you. But remember, hyponatremia can come with dehydration and hyponatremia can come with hypervolemia as well, right? Okay. So remember, whenever the patient is hyponatremic, then in the ICU, we are always checking the hydration status. Otherwise, your management is different. Okay. In hepatic encephalopathy, I'm just skipping this because it is different. You will be having the note and you will have a complete note at the end of the day. So fluid therapy in hepatic encephalopathy, the basic principle is we have to avoid the hypoglycemia because that is the killer in hepatic people, and you have to avoid hypokalemia and you have to avoid the hyponatremia as well, right? So stroke, I'm just giving you this, the whole note. So then you will have all the stroke. The basic principle is the initial treatment is maintain the euvolemia, avoid hypotonic fluid and hypoosmolarity, and avoid hyperglycemia. So these are the rules for the stroke patients. Now, at least you will understand, you cannot blanketly say this is how I treat, but you need to know the basics, then you can work it out, right? So in summary, select the appropriate fluid considering the etiology and associate electrolyte and acid-base disorders, right? In correction of hypovolemic shock in isotonic saline is the most preferred in shock bleeding, and the colloids and blood products we just discussed. In diarrheal situations, vomiting, now isotonic saline and combined with the potassium, combined loss and diarrhea rigorous lactate, vomiting isotonic saline and with potassium, and combined loss, then diarrhea vomiting dekama tiyana is the most preferred is rigorous lactate with supplemental potassium. In hyponatremia, principles of fluid and salt supplementation are totally different hydration status anuwa balanna. In hepatic encephalopathy, again, goal is to prevent all these electrolyte imbalances. So this is a rough guide. Hypovolemic shock, normal saline rigors, lactate, diarrhea rigors, vomiting isotonic, මම මේක දැන් කිව්වා මේ ටික කිව්වා. Adult maintenance එකට you have to make මේ ටික කපලා දාන්න, right? Okay. Right. So like this, I think we have discussed a lot of fluid status. Like now for the last word, the questions, you have seen questions. Next time I'm going to ask some questions on the fluid balance. Now the questions are being given. Anybody who has seen a question on fluid balance in the past papers? Anybody can see a fluid balance question in the past papers? I don't think you had time. ඔගොල්ලෝ නිදිද? ඔගොල්ලෝ හන්දනේ ඉන්නේ?
ඉන්නවනේ.
No. Very good. Right. So the famous question is, I love that question when I made it. Till then, today වෙනකල් හැමදාම කියවනවා එක. That is, I put one question once. 20 kilo child, 5% dehydration. Write the fluid prescription. Right? That's a good question for all of you. Please write the answer and send it to me. Okay. What the question is? 20 kilogram child, 5% dehydration. Write the fluid prescription. When you write a prescription, you have to write the volume. You have to write what fluid. You have to write in what time you have to give this to this patient. Okay. Good question. Kavishka?
Yes, madam.
Yes. In that question, you have to calculate the maintenance, you have to add the deficit, and you have to tell me what fluid to be given and in what rate. Hari? Okay? Right then. Thank you very much.
Thank you, madam.
Okay. I think we'll call it a day today. Ne? Tavat පැය ගානක් කියවන්න බැරි වෙන්නේ හවස. Huh? And too much for you all also. So we did trauma, we did head injury, we did fluid, right? So we have transport, we have some more, right? Okay, so maybe in another weekend or another evening I'll do. Okay, so please use this knowledge for your clinicals. Harida, is it good these type of classes can be used in others? All the other subjects also they can be used, not only us. Okay, then thank you very much.
Thank you, madam.
You're welcome.
Thank you, ma'am.
Thank you.
Thank you, madam.
Hope it is okay. Did I rush?
No.
Well, bit, but you will have the notes. I will කොහොමද මම එවන්නේ කාට හරි එවන්නද මේක දිනිඳු right is the batch rep නේ දිනිඳු ඔයාට මම මේක එවලා තියන්නම් the PowerPoint presentation.
Okay,
හරිද? And I'll upload the lecture to the Moodle. Yesterday එකත් upload කරා බැලුවද? බැලුවේ නෑනේ. I've uploaded that. Okay? Right. Okay then. Thank you. Bye.
Bye.
Take care ළමයි. පරිස්සමින් ඉන්න.